So thank you very much. Thank you for welcoming me. Welcome to you to our CE event this evening. We're going to be talking about therapeutic radiation. And one of the questions is, what does this as a specialty service in an already established veterinary community, what does it offer? One from the community standpoint, but also for mostly our pets and also the clients that own them. So I'm Rick Chetney. I'm a radiation oncologist. We are very happy, like Scott said, to be partnering with NorthStar VETS to be able to provide therapeutic radiation. So this is a very new partnership with the pet care radiation oncology specialists. So starting off with a little history lesson here, what was radiation to begin with? First, it started off with diagnostic radiation. This is a picture here of Wilhelm von Rankin, who was a German physicist and mechanical engineer, and he was trying to basically perfect some experiments that were performed on gas-filled or vacuum tubes with a little bit of an electric charge. And what happened was this X-ray exited the tube and started to illuminate this platinum-cyanide screen that he had painted, an aluminum sheet. And what he found was that it actually illuminated. So continuing his experiments over the weekend, he actually found that he could use these X-rays to go through an object onto diagnostic film and create an image. So this is actually the first publicly made radiograph here. This is actually a picture of Wilhelm's wife, and this is a ring on her finger. So when she saw this, her response was, well, I've seen my death. She could actually see the internal aspects of the bone of her hand. Shortly after that, Madame Curie started doing some experimentation with the radioactive metal radium. And this is one of the first rudimentary radiation treatments for a patient with head and neck cancer. Each of these blocks is a radium block that was put with this metal cowl up against the patient's face. If we were considering maybe this was some radiation blocking of the eyes so that we didn't get side effects there, but this is a very crude way of dosing radiation. We found that we had cancerous cells having their DNA busted up, they would preferentially die off. Now, the radiation side effects to these patients, which were much more severe. So fulminant inflammation, moist desquamation, actually given a long enough timeline, these patients had radionecrosis, so death of bone tissue, but also fibrosis of the skin and underlying connective tissue, muscle, things like that. However, during the time of radiation treatment, those patients had lesser disease and lesser pain from their cancer. So if they lived long enough, the trade-off was they had a longer survival time otherwise of a cancer that would be a life-limiting entity for them. So then they also did things like radium water. So adding this radioactive element into the water, it was first prescribed for ailments of like the GI tract and overall health. But again, now that we have a little bit more of an idea of radiation safety, from many different occurrences in the world, including radiation accidents and the dropping of the atomic bomb, we now know that this is a very antiquated and probably not appropriate type of treatment. So a lot of things that we consider, we still have clients, we still have, doctors, even specialists, on the level of education myself that are kind of, scared of therapeutic radiation. This is a toxic vendor. You may have recognized him from comic books, but this is kind of the view of what we think potentially our patients would look like after treating with therapeutic radiation. We think of radiation accidents, guys walking around in hazmat suits, even the, atomic energy, the nuclear plant accidents. So this was Chernobyl. And then we had Fukushima. And even the dropping of the atomic bomb on Hiroshima and Nagasaki. Interestingly enough, as far as our known tolerance of normal tissues to therapeutic radiation, we actually have extrapolated that information from the survivors from these acts, from war. And that is actually what we use as our dose limiting constraints when we're talking about giving radiation to different parts of the body. So we no longer think of therapeutic radiation as this very hazardous entity, and we can afford it with a very high margin of safety to our veterinary patients. The one thing that's different about veterinary patients is that you can have the best trained dog. You cannot have them jump up on the table and stay still for the radiation treatments. When we try to close the door and leave the room, that's where they jump off the table or potentially put another limb in the way of the radiation beam. So this is a little bit of an antiquated way of treating with radiation. This is called orthovoltage. So if you consider that your diagnostic radiograph tube that you have in your radiology suite, the energies of that beam is about 80 to 120 kVp. This is just over that. So being a very low energy beam, dose penetration into deeper tissues does not happen as well. We have a superficial dose distribution of the radiation. We also have, because of differences in density, with this lower energy beam, that dose is preferentially absorbed by bony tissue. So we had a lot of radium necrosis at an earlier time period after treatment with orthovoltage. It's also a non-isocentric treatment, meaning this dog for an oral tumor was treated with therapeutic radiation in a very square or rectangular shaped window. We had to flip the dog over on the Mayo stand to be able to treat the other side. So inconsistencies in patient setup really led to a much larger field of radiation. Then the advent of cobalt. So this is a radioactive source similar to radium that was up inside a gantry that was isocentric. So now we have a machine that moves around the patient who's anesthetized and static on the table. So the machine moves around what's called an isocenter, and that's the center point of our calibrated machine's highest dose output. We put that at the center of the tumor. We don't have to move the patient. We just simply have the machine move with multiple beams around the patient. And I should say that a lot of these older radiation plans were done on 1 to 4 beams. So you can imagine, even surrounding the tumor, there is a small margin of normal surrounding tissue that would get upwards of 25 to 80% of radiation dose. So this is a very linear accelerator. This is the oldest machine that I have practiced on. There are some out there that may have practiced on older. But this is a linear accelerator. So again, we're looking at the MV type of energy. That's about 1,000 to 6,000 times higher than what we use for diagnostic radiographs. Metal table, which is now replaced by carbon fiber, but you can see that there's no multi-leaf collimator on this machine. So basically you had your X and Y jaws, a very square or rectangular field. If you wanted to shape the radiation beam, you had to slide an acrylic tray in here with lead blocks and thumb screws to be able to shape the radiation beam. So in order to increase, accuracy of radiation treatments, but also to reduce the size of the radiation field, because we really just want to treat the tumor and perhaps on the order of a couple millimeters outside that tumor volume to account for microscopic disease, we now have linear accelerators that have KV imagers. So this is the KV, basically photon producer, so the source, and then this is the digital screen. If we take a static image, we have a KV radiograph. If we rotate the machine at the same time, we have a cone beam CT, and we'll look at that in the video a little bit later. This is an MV imaging plate. So basically you can use the higher energy of the radiation beam to form an image for treatment. And this is what was used with what we call conventionally fractionated radiation therapy. So we didn't have as good of resolution between soft tissues and also bony tissues. So it was a very flat image, very hard to see some of these tumors that are located in different parts of the body, especially when they're located in the middle of soft tissue. So as we look to the future, we have our newer machines and newer radiation oncologists. Okay, radiation itself, very fancy terminology. We can speak about it with a little bit more fancy words and things like that, but really at the end of the day, radiation is a DNA buster. So what happens is the photons or the electrons from the machine interact with a water molecule in our bodies. Good thing we're made of about 80 to 83% water. And what happens is an outer shell electron from the actual tissues of the patient is liberated, interacts with that molecule to form a hydroxyl radical, and that's what actually interacts with the DNA to cause a double-strand break. The good part about our normal tissues is that DNA damage, the double-strand breaks, are repaired by normal mechanisms, whereas the cancer is not as efficient in repairing that, so we have preferential tumor die-off while we have healing of the radiation effects to the normal tissues. So what is the machine? So basically it is a high-powered X-ray tube. We are using electrons from the back of the machine from a tungsten filament. it bombards on a tungsten target, and we produce X-rays or photons. Those are what we're using to create that double-strand break interaction in the patient's tissues and the tumor. If we remove that tungsten target, we've used these linear accelerators to treat with electrons. Because those particles are not as forward directed as photons, we can harness the energy, kind of comes out in teardrop shape, and we can basically shape the field and treat superficial tissue. So electrons, the benefit is that once it penetrates into dose, the dose fall off is very rapid, rather than you can think of a photon. The reason why we have diagnostic radiographic images is because that photon goes through the body and develops on the film on the other side. So with the advent of this linear accelerator with an isocentric treatment, again, we can move the radiation beams around the patient. We can really treat any tumor in any location of the body from any angle. And now we have the addition of the Halcyon. So the Halcyon itself is very similar to a CT scan. On the linear accelerator head, there's the KV imager. Then we also have the MV linear accelerator head that does the therapeutic radiation treatments. So some of the side effects of radiation, things to consider is that radiation does not burn. It doesn't melt tissue. We certainly do not create any avascular fibrotic area tissue or eliminate surgery as a future option. So I've heard some specialists that may not be as versed in the technology of therapeutic radiation, and of course, because of our previous technology causing more severe side effects, it becomes a little less recommended as a radiation treatment. However, we're going to talk about that technology this evening, so that we no longer have fear of that. So we do not create melted faces, and we also don't create zombies secondary to therapeutic radiation. But all treatments do have side effects. So when we're thinking about surgery, I think by far and away, our clients, even ourselves, we don't bat an eye when we're thinking about removing a tumor with surgery. Side effects of surgery: if we do not remove enough of the tumor, we have the high likelihood of tumor regrowth. If we take too much tissue, then we leave a surgical defect that may be disfiguring or decrease the function of the life of the patient. Same thing with oral medications. We don't hesitate to take an aspirin for a headache. We don't hesitate to take medications for other disease processes. If we're underdosing, that disease continues, but if we give too much, we can potentially cause a toxicity that may result in death. So radiation itself has to be prescribed for the highest effects to the tumor itself, but the lowest effects to the normal surrounding tissue in our patients. Here's a visual of basically the improving technology. So back in the orthovoltage days, very low energy beam given with this orthovoltage unit here, even stepping up to a rudimentary linear accelerator without that beam shaping capability of a multi-leaf collimator. These are the side effects for a nasal tumor. I should say that the reason why these images are compared is because the internal aspect of that tumor was basically a full nasal cavity worth of tumors. So radiation side effects were given over a similar volume as compared to each different volume of a dog. But you can see that there is much lesser side effects in this patient with that higher energy. In the orthovoltage days, we had fulminant inflammation. This is a patient that is super painful from the side effects of radiation. And we're treating a nasal tumor, but we have effects almost from the tip of the nose and then back over the top of the forehead. We should not, as a function of prescribing our radiation therapy and using our imaging technology to make small radiation fields, we should not have this preferential superficial dose of radiation, and we shouldn't have these skin effects. You can see that the skin of this dog with megavoltage radiation, we can see nice pink healthy skin. The reason why we have a little bit of a crust or a scab here is because the owners were a little hesitant to put on topical ointment and do daily cleansing. However, if that was performed, this whole area should be nice, pink, healthy, non-inflamed tissue. And that fur does tend to regrow at about the 6-month time frame. So oftentimes we have a different color of that fur return. Lighter dogs tend to go a little bit darker in their fur color. Darker fur dogs go a little bit lighter. The benefit is we now have a visual marker of where the radiation beam was given. We can monitor that area for regrowth of tumor. And now with a multi-leaf collimator, which are individual lead used to pull into the radiation field, we can actually shape the radiation beam to just treat the tumor. I haven't treated a square tumor yet, so having a radiation beam that is around the confines and the contours of the tumor is really helpful. Also, intensity modulated radiation therapies, where we are trickling those little leaves across the tumor, and instead of opening a big field and just giving radiation, we're actually fan-shaped brushing that radiation over the field so that we have lesser surrounding tissue side effects. We can actually shape that field, and we can preferentially decide which parts of the tumor get a higher dose, which probably is the parts of the tumor that are further away from organs at risk, such as frontal part of the brain, the eyes. So this patient here, Max, he had radiation therapy. These are at the same time frame, in those 2 weeks after radiation therapy is completed. Max looks like the healthy, happy dog that we all want to have. And again, with a linear accelerator with a multi-leaf collimator, which the Halcyon has as well. For some types of cancer, unfortunately, we do have to treat the skin surface. So that would be surgical scar lines, where we're considering that the surface is contaminated with remaining cancer cells. So for this patient, an easier, I guess, less technologically involved radiation plan called open field parallel oppose. We can basically have 50% of dose to either side of the limb. But what happens is that superficial dosing is a bit higher. So what happens is patients may become a little bit lame or uncomfortable in the third week of therapy. We usually cover them with an oral nonsteroidal anti-inflammatory drug. So something as easy as Rimadyl or meloxicam that generally takes down this inflammation quite a bit. This patient, however, just needed the additional dose of gabapentin for help. And typically what I use is the 5 milligrams per kilogram dosing of that medication. We started out at twice a day. We can always increase the frequency first to 3 times a day and potentially go up on that dose, because gabapentin does have a pretty wide therapeutic index there. The patient was also licking this site. So client education on all of our discharge instructions. We talked to them about daily cleansing, also use of an e-collar to prevent self-trauma. There's actually a study from, I believe it was like the late 60s. For whatever reason, I'm thinking of 1967. There was a study that the claim was dogs had worse radiation side effects if they were allowed to lick their sites. And it's not necessarily that the radiation dose became worse from licking. It was that there was secondary self-trauma and introduction of bacteria to cause an infection, which becomes worse. And then the site looked less than ideal, so we just reminded Dad, you should be doing daily cleansing. So just a soft cloth over the radiation site, 10 minutes at a time once a day, and then apply a very thin layer of Aquaphor. So in 2 days' time between these photos, if this was merely from therapeutic radiation side effects, we shouldn't see this nice, bright, pink, healthy tissue on the surface. So very similar to this patient here with those skin changes here. And then this is the video that Dad sent to me after he had added on the gabapentin and done the cleansing and kept him from licking. You can see that Coco here has his radiation side effects, but he's putting full weight on there, and he's actually asking for his dinner, I believe, at that time. And then again, in that 5 to 6 month range after therapy, we do have the fur regrow full thickness. The good thing about our patients is that they do have fur in this area, so this is not quite 6 months out. I would expect a little bit more of the fur to grow toward the surgical scar line. But because they're furred animals, oftentimes the fur grows back, or hopefully if they're longer and fluffy hair, we can do a little comb over so that we don't see, the original bare skin and surgical scar line. What we want to avoid with therapeutic radiation is multiple surgeries. So if there, is an area where therapeutic radiation is not available, oftentimes the consideration is, do we just remove the tumor multiple times? Really, the first time of cutting really is the first chance at removing the disease. Soft tissue sarcomas need at least 3 centimeters of normal surrounding tissue to be removed with the tumor, so that we have what we call surgical curative intent. That being said, if we don't have those margins, just one cell left outside of the surgical field may repopulate into a tumor. This patient here, her name was Sydney. She had an original soft tissue sarcoma kind of on the lateral aspect of the gluteal region, kind of thigh area. First surgery resulted in a scar line to this point here, kind of on the caudal aspect of her thigh. Second surgery is another scar line here, tumor regrowth here. So we have a third surgical scar, and the fourth surgical scar kind of goes from the dorsal sacral area to the perineal area. This patient going through 4 or 5 surgeries, the thing that we would want to totally bypass or eliminate as a potential for this patient is if we get the biopsy back and we know that we don't have surgical margins from that first surgery, first recommendation is, can we take more tissue? Because for most of our tumors, cutting the tumor out and getting it out of the body is our best chance at what we call surgical intent. Next best option, if we can't take more tissue and leave better physiologic function of the patient, is to add some form of therapeutic radiation. So there was a chance that if we had gotten that original biopsy back, realized that we couldn't do a second surgery to get margins, one round of therapeutic radiation would have about a 3 to 5 year chance of this dog not having a regrowth of its tumor, about on the order of like 80 to 75% for soft tissue sarcoma specifically. And I would argue that that is probably secondary to review of some of our antiquated literature. I think with more of our stereotactic capabilities, which we'll discuss in a bit, I think that we can actually spare skin dose and actually get a higher escalated dose to the tumor itself, so that potentially our tumor control and our survival times could be longer. So when we're talking about therapeutic radiation planning, of course, the easiest plan is to do one top-down beam. The problem with that, however, is that the tumor and then a wide margin of normal surrounding tissue is also receiving that 100% dose around the tumor bed. As we increase our beam angles, again, if we're talking about MV imaging, so not having a cone beam CT on there, we might be considering 1 to 4 different radiation beams. But still, we're looking at 12.5 to 25% of radiation in normal surrounding tissue that may have a late side effect. Now, late side effects of radiation are basically contingent on the overall individual dose of radiation per treatment, and then it's usually in slower turnover rate tissue, so bone, muscle, nerves, things like that. But they can be a very big problem for a patient, kind of in that 6 months to years down the road. So the more radiation beams we add into the plan, potentially we might be able to increase or escalate this tumor dose, and we're spreading the dose around the normal surrounding tissue so that it gets much less dose. We also use those individual lead leaves pulled into the radiation field to reduce scatter dose and therapeutic dose to the normal surrounding tissue. So just like your diagnostic X-ray tube, we also have X and Y jaws on linear accelerators. We can, for the conventional linear accelerators, we can do anywhere from a 40 by 40 to 3 centimeter by 3 centimeter field. And then the radiation, if we were looking at into the linear accelerator beam head, the radiation would come out of that window. Now with a multi-leaf collimator, these are individual lead leaves, and this would be what we call a dynamic 120 MLC. So 120, 60 on either side, individual lead leaves on motors that we can pull and shape the radiation field, thus creating a much smaller radiation field and also knocking off the corners, so they can really just treat this 3D tumor volume rather than cuboidal volume. And if we have those individual lead leaves in motion, we have what's called intensity modulated radiation therapy. So intensity modulated radiation therapy, we're increasing the number of beams to 5 to 9 beams, which comes up as individual beam lengths. So this is almost like a pencil thin beam, but we have multiples of them at a time. It's kind of like a fan-shaped brushing of radiation dose across the tumor bed. The idea is that we're actually putting in dosing constraints. So what we want is highest tumor dose possible, but we also want to make a minimum allowable dose to the normal surrounding tissues such that we can sidestep adverse side effects. So for this patient here, this is a human with a mantle treatment. So this would be for like lymph nodes and mediastinal lymph nodes for like lymphoma. This would be the treatment. So these individual lead leaves are in motion while the radiation beam is on. So fan-shaped brush, and when somebody like Bob Ross is at the helm of your treatments, you know that everything is going to be a better day and excellent with your treatment. So this is a case from my residency. This is Max. He was that Belgian Malinois that had a fairly large nasal tumor. The owners elected to do intensity modulated radiation therapy because they said if this dog has any kind of side effects, he enjoyed going to the agility course every day and actually competed. So those superficial skin effects were not allowable. So this is one of my first IMRT patients. We did the conventional fractionation of a very low 3-grade dose. That's a dose of absorbed radiation, but that was over 16 treatments. So we could do 1 day of double up. We did Monday through Friday over 3 weeks. This is not max, but this is a very similar therapeutic radiation plan. With intensity modulated radiation therapy, you can see that the dosing lines are actually bent away from normal structures. So the frontal part of the brain, the eye, we can actually bend that dose away so that we're doing what's called conformal avoidance of normal surrounding tissue. And you can see in here our what's called planning target volume. That is a small expansion 3D around the tumor that we're prescribing the radiation dose to. We'd like to cover it with 100% of the dose. So the 100% dose line was about this 50.4 gray dose. And you can see, again, this color wash, everything within this red lighter cloud is that 100% dose. We're getting that out of the eye there. So previously, this is a nasal tumor without IMRT. This is what's called 3D conformal radiation therapy. Basically, it's those 1 to 4 beams with a multi-leaf collimator, but we're not doing that intensity modulation of bending these radiation dose lines away from the patient. Just like a topographical map, the 95% dose line is this yellow line here, 100% is the red line. So as we go up each individual step, just like on that topographical map, 100% doses at the higher parts of the hill. The lower parts that are more expanded to the outside are those lower doses, albeit you can see this 95% dose is actually going just about in the middle of this patient's eye. So it used to be choose an eye. If we have a nasal tumor, choose one, try to spare one, but usually you're just leaving the patient with one eye long term. With IMRT or intensity modulated radiation therapy, we can try to spare all the normal surrounding tissue. And then we have stereotactic therapeutic radiation. So that's using higher imaging technology. We are treating just the tumor bed itself and a very small 2 to 3 millimeter planning target volume. So those 2 to 3 millimeters outside of what is visible with the tumor. So we have tumor here, and then this red line denotes that planning target volume. You can see the 95% isodose line, this color wash yellow here, is just around the tumor. We're missing the frontal part of the brain, this Chihuahua patient, and we're missing this eye. I would stand to argue that a Chihuahua patient with a very large nasal tumor is probably more difficult to treat than the same volume of tumor in, say, a Great Dane. So we take, excruciating lengths to make sure that this dose is compacted in a very small volume and that we're not getting significant normal surrounding tissue volume. This dog may have a cataract from side scatter radiation, but I'm not considering, fulminant radiation-induced dry eye, conjunctivitis, or loss of an eye. Long term, it used to be that dogs that were treated on a 3D conformal platform, 50% of them or 56% of them would go blind in at least one eye, sometimes requiring enucleation. We see that from another comparative study with IMRT. We found that in that specific study for the historical controls, the newer type of treatment with IMRT, 0% of those dogs went blind in either eye long term. The other thing I wanted to use this photo for is to mention immobilization devices. So you can see what's called thermoplastic mask. So this is a flat kind of polka dotted sheet. It's got holes in it, but you put it in a hot water bath, and just like cast material, it becomes very pliable. We stretch this over the patient to totally immobilize their head into this bite block. So this is a carbon fiber stage with a little bit of that thermoplastic material that we create a dental mold for. This is what locks a patient's head in while under anesthesia. We can see the endotracheal tube here. This is what helps to hold the dogs fully still. We do have our patients under a very light general anesthesia, so they don't move, but there still is that respiratory motion. So to account for that, physically immobilizing them will make sure that we can get what we call sub-millimeter accuracy. So I want to make sure this radiation beam, if I'm using 8, 9, however many beams, I want to make sure that the isocenter is hit. I want to make sure I'm hitting the direct center of this planning target volume for each location, the exact same location each time. And the accuracy on that is below 1 millimeter. So what we're doing with stereotactics is not only are we sparing normal tissue, but we're trying to completely avoid organs at risk that are around the tumor field. Here's a video of a cone beam CT being performed on a patient. So I believe this was a head and neck tumor patient. What you can see is once we export the cone beam CT, we get a 3D image. So we're having CT slices just like the original planning CT for these patients. So patients that go through and get like a CT simulation, that is what we use to plan our radiation. We're outlining the tumor. We're also doing contours over the normal organs. So the lobes of the eyes, the brain, lining of the mouth. And what we do is once we take our images on the day of treatment, we have what's called bone-on-bone overlay. So we use our cone beam CT technology to make sure that the patient is in exactly the same location each time that we're giving radiation. It's just an assurance that that radiation beam is going to the same location and that our radiation fields are not spread out over the tumor volume. It's actually pinpointed to the tumor itself. This is actually an image from my residency. So this was a dog with a brainstem tumor. You can see the multi-leaf collimator leaves in this beam's eye view. You can see them actually cut out in this image. This is what's called a digitally reconstructed radiograph. So this would be basically a radiographic image off of the planning CT. And then what we had here was actually radiographic film. So this would be an image that we would take while the patient's on the table. We'd run across the hospital, develop it in our developer, and then take it back to the control room and look in a light box and compare these two images to make sure that we were, the best we could eyeballing the accuracy of the beam placement. Here, we don't have to worry about eyeballing between two screens. We have those images that we can overlay. Once we have the patient in position where we want to treat them, the machine automatically tells us where the table needs to be moved. And if there's concern, we always move the patient, or I'm sorry, we always image the patient one more time to make sure that we have that sub-millimeter accuracy before doing the treatment. So this way is a little bit antiquated. I would say that places that are offering intensity modulated radiation therapy and definitely stereotactic radiation therapy, you're going to want your cone beam CT for that sub-millimeter accuracy. So Max's radiation side effects with intensity modulated radiation therapy, again, 3 days after treatment, 20 days after last treatment. He had a little strip of skin that fell out, and one of his eyes was kind of winky for like a day. He did not need oral non-steroidal anti-inflammatory drugs, nor did he need topical tear replacing gel, and his quality of life was preserved with treatment. I'm going to do a couple cases now. So intensity modulated radiation therapy, again, that type of radiation delivery is what we also do with stereotactics. With the stereotactic format, we're just increasing the intensity of dose. So the dose fall off outside the tumor volume is very rapid. We go from 80 to 20% dose within a 2 millimeter span from the edge of the field that we're treating. This tumor right here was a transitional cell carcinoma in the bladder of this 25-pound Pomeranian mix named Smokey. This is his pre-treatment CT, so this is what we used the images for treatment. And this is his 6-week post. So basically urinary bladder here, we can see the penile urethra, abdominal contents, and these are the bones of his sacrum and ilium. Comparative image 6 weeks later, we see the balloon of the Foley catheter, but this intraluminal tumor here has been reduced to this little spit here. So he had a very good response. Unfortunately, we lost him to follow-up as we had contacted the owners, but did not receive a call back, and we're hoping that he was doing just fine from that treatment. This is a very large suspected pituitary macroadenoma that I was acquainted with in January 2017. This is his pre-treatment CT, and I had the blessing to do his treatment over the month of January 2017. Unfortunately, halfway through treatment, because of this pituitary macroadenoma and us being under anesthesia, he did go into seizure activity, so we did have to add on some antileptics for him. But you can see this macroadenoma here is about 56% of the total brain height of this patient. This is usually a patient where we would consider either some form of palliative therapeutic radiation or humane euthanasia. So after being turned away from the CyberKnife Center, I had this case come on my service, and Georgie's mom had actually said, "I'm not interested in palliative means of treatment. I want to do whatever we can to do full course and curative intent." And I said, okay, and I crossed my fingers and I took a deep breath, and we went ahead and did that treatment. So this is about 7 months later, and this is Georgie with a 33% tumor height to brain height ratio. He was actually, in the month after therapeutic radiation was completed, he was seizure free. He was no longer lethargic, not eating his food, having back leg shaking. He was returned to normal Georgie. We got a further recheck CT scan. So this is in 2018, just a little over a year and a month, so 13 months after the therapeutic radiation was given. This tumor is about 30% of overall brain height. And then this CT scan, 2019, so again, almost 2 years later, I had a very difficult time even finding remnants of the tumor itself. So this is just to say, what the visual success of treatment with therapeutic radiation, especially when we get into higher technologies of intensity modulated radiation therapy. And this is Georgie, just about the time before his first recheck CT scan. So a month before, Mom actually sent me this video saying, "Thank you so much, you've returned my dog to me." So we don't have a dog that's totally sullen and lethargic at home, and he can go outside. And one of his biggest joys in life is to play fetch with his dad out in the backyard. Okay, weird tumors. Because our patients don't exactly always read the textbooks, this is a cat patient that was actually near the same time as Georgie that happened onto my service. He had a neuroendocrine carcinoma. So these are tumors that you think of that are glandular structures that usually are involved in metabolic processes. So your pituitary glands, your thyroid glands, adrenal glands, anal sac carcinomas, those are all in kind of like the neuroendocrine categories. This was a neuroendocrine tumor that was just kind of floating in the chest. So it wasn't really adhered to any structures, albeit we do know ectopic thyroid tissue can be anywhere from the base of the tongue to the base of the heart. But we didn't have any formal diagnosis because it didn't seem to be associated with really any organ. So this is the pre-treatment CT scan. We can see aortic arch here, and then the outline of the tumor inside this cat's chest. We have the scapula coming over this, ribs here. This is the dorsal spinous process. And then with his post-treatment recheck CT scan, June. So again, we're looking at about 5 months after treatment. The tumor itself was only reduced about 17 to 20% overall volume. However, the original presentation for Jimmy was dyspnea, coughing, just exercise intolerant at home, as much as cats can be active and do exercise. But shortly after treatment, the owners had called me, in those 2 weeks after treatment, saying that his cough totally went away. He actually started regaining body weight because he was feeling better and eating. And this is about 14 months after his treatment was completed. This is Jimmy kind of sunning himself on a rock, hanging out by the fireside. You can see that there's a little bit of weight gain between these pictures. So this was a little bit sooner, but again, a family that's very appreciative and looking at options of either doing a very invasive surgery or potentially, performing humane euthanasia if his quality of life, was not good. So stereotactic therapeutic radiation or radiation therapy, SRT, SRS, SBRT, we're going to break down some of that terminology. Lars Leksell was a Swedish physician who, back in 1957, developed a means of dosing therapeutic radiation to very small volumes. So this is actually a head frame that was used as a biopsy instrument for neurosurgeons. They could pinpoint a lesion within the brain cavity in an XYZ coordinate to be able to introduce a small biopsy instrument, take a sample, and then decide, is this a brain tumor? Is this an arteriovenous malformation? So then what was developed was the gamma knife. So this is like 201 individual radioactive cobalt sources. They each have an aperture that can open to give radiation in a pencil thin beam. And the idea is to have an isocenter, just like our linear accelerator, from all kinds of different, again, 201 different beam angles that all converge into the center of the tumor or this malformation. So it's a three-dimensional coordinate system, X, Y, and Z planes, to be able to do these treatments. Then came the CyberKnife. So this is a machine where instead of doing 201 individual radioactive sources, we have a linear accelerator head on a robotic arm. This is the same arm that is used in the vehicle manufacturing factories to be able to give radiation from anywhere from 180 to 200 plus angles. This tabletop will also move. So if we have a patient breathing, if we have fiducials that kind of target the outside of the tumor, this table and the machine will actually move with respiratory motion, so that we're just treating the tumor with stereotactic radiation and we're not treating normal surrounding tissue. Linear accelerators, again, have the same idea. There is breath gating machinery that can be used. So it's lasers on the ceiling with a diode receptor on the patient's body, that anytime the patient breathes, the radiation beam is cut off, and then it resumes once the patient is still again on that long expiratory pause. And now, of course, we have the Halcyon as well. This is the foot of the table camera to visualize the patient. And again, we can do a 3D cone beam CT on this patient, make sure that we have our imaging set up of our patient exactly where we want them, and then send them through the machine and treat them in a conical helical version of radiation therapy. So SRS is really radiosurgery terminology. It was previously used as terminology to talk about single central nervous system lesions, and because it was called surgery because that was a single event, just like regular surgery with scalpels. With stereotactic radiotherapy, we're looking at anywhere from between 2 and 5 doses. Most of our protocols are completed over 3 consecutive dates. Stereotactic ablative body radiation and stereotactic body radiotherapy are basically synonyms, but you may see this kind of terminology for locations outside of the central nervous system. And our individual treatment size, rather than being 3 gray for conventionally fractionated radiation therapy, generally we're looking on the order of 9 gray to even like 10 to 15 gray sometimes. We can do single doses on the order of 20 to 22 gray, and that would be for specifically some of our round cell tumors that I've seen our protocols being prescribed for. So the Gamma Knife being those 120 individual sources, and the CyberKnife being basically, 201 individual sources. The CyberKnife being a machine that can actually move and make pencil thin beams from individual angles. We're looking at 100 to 200 plus pencil beams. The unfortunate part about this, because we are involving anesthesia with our veterinary patients, these anesthesias tend to be quite long. So we're looking at about an hour and a half per treatment versus a variant linear accelerator or Halcyon that gives individual pencil thin beams, multiples of them, these fan-shaped beamlets. We can actually complete those treatments on the order of 30 to 40 minutes. With the Halcyon, even faster than that. We're probably looking at about 20 minutes. So this picture over here, pencil thin beams. The other consideration is dosing spheres in a non-spherical tumor. We may have areas where we're overlapping really high dose. That doesn't concern us so much if that's in the tumor volume. It does concern us when we get out to the patient edge, and really an argument against these types of treatments is really just the long anesthesia. However, stereotactic radiation therapy given by CyberKnife or the Halcyon or our varying linear accelerators, the Xeon conventional type of linear accelerators, have given us very good lesser side effects for patients, but also potentially longer tumor control times. For a geographic miss, again, there's a potential for that. We are using smaller expanded volumes of the prescribed volume where radiation is going in these patients. With more antiquated means, if we're talking about 3D conformal, we're usually treating on the order of like 5 to 10 millimeters of normal surrounding tissue outside to account for that microscopic disease. With stereotactics, again, because we're using this higher imaging technology, the cone beam CT with a bone-on-bone overlay, we can treat the tumor at a very small margin of a couple millimeters outside of the tumor volume. We also know that that setup is going to be that sub-millimeter accuracy. One of the interesting questions is, and this is something that's in clinical trials in both humans and pets, is do ablative doses of radiation stimulate the immune system? So the idea is we're giving these high ablative doses to the tumor itself. Do we, in fact, for the microscopic disease that's going to be outside that tumor volume, do we enact the immune system to go ahead and take care of those cells and attack and kill those cells? And the question still needs to be proved, but we speculate that we have at least anecdotal evidence that it does happen. The other consideration is the abscopal effect. So that basically means we give a localized tumor therapeutic radiation, and chemical messengers from the dying cancer cells will travel systemically throughout the body and may end up in areas such as pulmonary metastatic disease or metastasis in the bones. So not only are we giving a localized treatment, the anecdotal information is that we may be actually having distant therapeutic radiation effects on the disease as well. So combining that with chemotherapy, that just gives us more tools in our arsenal to give the best treatments possible. So again, when we're talking about the changing technology, as our technology improves, our imaging and patient positioning and immobilization devices become much improved. We go from this kind of 50% dose from either side. So this is a human patient, base of the skull over here, spinal cord, dental arcade. So these are areas of the mouth and salivary glands. We go from this very much larger cuboidal field. With the advent of 3D planning, we can actually shape that radiation dose around the disease and maybe spare superficial skin. Most areas of the mouth, we're still getting some tongue dose here, so this patient is going to have oral mucositis, maybe sparing the spinal cord here. With IMRT, so intensity modulated radiation therapy stereotactics on our newer linear accelerators, we can really treat disease. This patient, I wouldn't expect to have superficial skin effects because it's an internally located tumor. So the only time I'm worried about moist desquamation is when I know that my radiation dose is going to go to the surface. For deeper located tumors, that is not much of a concern. We can actually outline the skin as one of those dose constraining areas so that we're not getting those side effects and we're still able to give curative intent and doses to our deeper tumors. So like I said, I haven't treated a square or cuboidal tumor yet. We should just really employ this higher technology to be able to treat things that are similar to 3D monitoring. So there's a ton of different options out there for radiation therapy. Proton therapy, we get some questions about that from time to time, albeit for veterinary medicine itself, I don't believe proton therapy is at an advantage over these newer linear accelerators that we have at our disposal. The other consideration is that proton therapy treatment sites, their units are on the orders of millions of dollars. So it's very cost prohibitive for veterinary patients and human patients alike. Really, as far as I am knowledgeable about, the benefit for this type of radiation therapy is for children with retinal blastomas because they have the option of potentially, if we can treat their disease, they may live outwards of 40 years plus, and we definitely have lesser radiation dose to the normal surrounding brain tissue, which might lead to cognitive dysfunction. We don't see that in our veterinary patients. For what imaging technology and the therapeutic radiation we have, that doesn't seem to be something that benefits our patients with proton therapy. These are different fractionations. Conventionally, we used to do 16 to 20 individual treatments over 3 to 4 weeks. We're now able to give curative intent with 3 to 4 consecutive day treatments. And the method by which we treat, again, we have these different imaging technologies and machines at our disposal. So I think PetCure is kind of at the forefront of deciding, with the technology trigger, of course, we want to use it for every tumor possible. So we think that, their linear accelerators, stereotactic treatments, it's all going to be great for all the different types of tumors. We have seen tumors that maybe we have more side effects. Maybe we don't have as good survival times. So now we're starting to think, is this technology something that we want to employ? I think where PetCure Oncology is, we're kind of at the forefront of things right now. So we're deciding and actually having clinical trials that come back with information telling us what types of treatments, what types of machines, what types of protocols are, again, for lesser side effects of normal surrounding tissue, but for the utmost return of quality of life of our patients. and also potentially longer tumor times, median survival times and tumor control. Basically, if we can avoid all normal surrounding tissue, we can actually escalate the radiation dose so that we may be able to get more of a longer cure time. So what cases do you send to the medical oncologist? The things you should be thinking about are systemic disease, so tumors that have a high rate of metastasis elsewhere in the body, but also tumors by function of their biologic behavior are systemic anyway. So lymphoma, leukemia, definitely multiple myeloma. For lung tumors and liver tumors, we do have chemotherapy at our disposal, but we would also argue that if these tumors are of a reasonable size and also in a location where we can treat them, stereotactic radiation may be in addition to chemotherapy for treatment for these pets. Bladder and prostate tumors. There's a study out there that said actually addition of radiation therapy doubled the survival time from the 9 to 11 months we saw with non-steroidals and chemotherapy outwards to about 22 months. So that remains something really exciting for the future. And then bone tumors after limb amputation, we like to send our osteosarcomas to the medical oncology specialists for follow-up chemotherapy. Radiation oncology, you should be thinking about tumors that are localized, that aren't in the body. Palliatively, we can definitely treat different metastatic centers. So with stereotactic radiation, that allows us to treat painful bony metastases from things like our prostate and bladder tumors. We can also use it in a palliative to curative intent for bone tumors. So if there is a older dog where amputation, is not recommended because of significant osteoarthritis, and the dog just wouldn't do well on 3 legs, especially in higher body weight patients, we can do a form of stereotactic to do like a limb salvage procedure that doesn't include surgery. So this is where therapeutic radiation is a value-added service. This is something that is kind of new in this area. So in the western part of New Jersey, this is the first time therapeutic radiation is available. With PetCure, like Scott had said, you do have the experience of 10 radiation oncologists plus medical oncology specialists. We're also associated with criticalists, surgeons. So really, we utilize the specialties that are on site. But you can also rest assured that a medical physicist for dosimetry and then also 2 radiation oncologists are looking at every plan before therapeutic radiation is given to pets. Referrals. So in-house referrals, definitely if a patient needs a different service. So in the case of an osteosarcoma, surgery is the better option for the patient because that is the longer survival time in some cases. Surgery with follow-up chemotherapy can be recommended. So we work very closely with our other in-house specialists. We're also associated with clinical trials. So there is a list of clinical trials for various types of tumors that are always ongoing. Not only that, but I think PetCure is really good on having the finger on the pulse of clinical trials that are available at other sites. So enrolling patients in some kind of cutting edge therapies is something that we can afford. The affiliate program. So this is something where we have an online portal. You can actually get into a chat messaging window on your computer and send back and forth images, blood work, and actually have like a hallway doctor-to-doctor consultation for your veterinary patients. And then I believe I might have a similar number. This and the other one that Scott provided previously is for a pet advocate hotline. So for clients and also for doctors that want to have their patients enrolled in therapeutic radiation, this would be a number to call for PetCure. Okay, and now while I scroll through some patients that I treated previously, we're going to entertain some questions. Peach face lovebird. This was a white ferret, a goat with a thymoma, lion with an oral melanoma. This is one of my favorites, the tiger with a squamous cell carcinoma in the corner of the eye. And of course, a bull with a squamous cell carcinoma.